All right, everybody, let's go ahead and jump into this case scenario. So it looks like we have a 15-year-old patient or client who is a Puerto Rican adolescent female. Looks like she's living with both of her parents and a younger sibling. So coming at this from a biopsychosocial standpoint, I think it's important to identify this right off the bat. So we have an adolescent here. We also have a Puerto Rican female adolescent living with both parents. So I think it's important to, at least in the very beginning, consider possible cultural factors going on. Puerto Rican culture. She is an adolescent female living with both of her parents, younger sibling. So it's just something that we should really keep on our radar to see if there's any cultural kind of issues that may pop up. So let's continue on. Let's see how the symptoms play out. It looks like her parents are having significant marital problems and have been separated several times. So obviously that, as a clinician, I'm already kind of concerned that not only are they having current medical or marital problems, but that they've had separations in the past, and what that does to an adolescent's development, the family structure, the possible worries and concerns having had who knows what's caused the separations in the past. It may be domestic violence or arguments, who knows, but obviously being separated several times involves likely some significant issues going on at home. And then it looks like they're currently discussing divorce. So obviously this home life is pretty, at least right now when it comes to her parents, pretty tumultuous, and something to consider as causing significant distress in her life. It looks like, if we look here, it looks like her mother reports having a history of psychiatric treatment for depression and anxiety. So I'm definitely going to highlight that. And the reason I'm going to do that is because as we do a biopsychosocial, or look at it from a biopsychosocial lens, we're definitely considering the biology of this, the psychological history. And if you have at least one parent, blood relative, that has depression or anxiety, the likelihood of, this current patient or client is definitely increased. And then it goes on to say that her father also looks like suffers from bipolar disorder and has been receiving psychiatric treatment. So this 15-year-old adolescent is having issues or having influences from both sides of the family. And if we remember, about depression, anxiety, that's got a pretty high likelihood genetic wise to be transferred. We know bipolar disorder involves, or definitely can involve, having major depressive episodes. So it's almost like we have depression from this end, we have possible, likelihood of depression from the bipolar end. So this 15-year-old is really kind of set up at this point to potentially, if anything that's, is potential for depression is likely in this case, as well as some anxiety. So that's something to pay attention to. And again, in finding out about family history, this doesn't mean that it's self-fulfilling and it's determined that she will have these issues, but that's the purpose of gathering a good, solid psychological history, especially of the family, is because it may help us understand what the likelihood, or there's a probability of these type of diagnoses. And it looks like even the father was hospitalized on multiple occasions for serious psychiatric symptoms, which means his bipolar likely, if we're taking that into account, then if we remember kind of the differentiations of bipolar, if you're ending up in the hospital for serious psychiatric symptoms, it's likely bipolar 1. Just because of the severity, the marked impairment, the hospitalizations. Again, I'm not diagnosing him, he's not my patient, but definitely just from this brief description, we're finding out that landing in the hospital for serious psychiatric, and he has a history of bipolar, is lending itself to some sort of bipolar 1 diagnosis. So let's continue on though, and let's focus back on the client. So it looks like she was failing several classes in school, and it looks like her parents were in the process of looking for a new school because of her failing grades and difficulties getting along with her classmates. So it looks like there's a couple of things going on to consider whenever adolescents are beginning to fail school. That's concerning. That can often be signs of depression. And it looks like she was having difficulty. Her grades were also falling and difficulty getting along with classmates. So some of the conditions then that we're considering right off the bat here. So let me kind of write these down. So it looks like major depressive disorder is one that's kind of based on family history, as well as kind of some of these early signs. We may want to consider anxiety based on family history, bipolar based on family history, having difficulty getting along with classmates. It doesn't say that she's any sort of violence or anything, but we can put this down as maybe oppositional defiant disorder, maybe. If she's not getting along, maybe she's talking back to her teachers. We don't know yet, but let's just put that down. So we've got a few different diagnoses being developed, or maybe need to be ruled out at this point. So let's continue on. It looks like she presents with the following symptoms. So let me change the label here. So it looks like sadness and crying. Okay, that lends us towards certainly depression, or at least depression and or bipolar. So we're kind of headed down that route. Increased appetite and overeating. Certainly that's pretty congruent with depression. Guilt. Yep. Low self-concept. Yep. Anxiety. That kind of brings us back to maybe anxiousness. Irritability goes along with both anxiety and depression. So that's there. Insomnia, same thing. Depression, anxiety, hopelessness, certainly more so on the depression end, back towards maybe part of bipolar diagnoses. Difficulty concentrating, that can go along with depression, anxiety, and even bipolar disorder. So kind of we have all of these things still in the race. It says that she's presented difficulties in her interpersonal relationships, persistent negative thoughts about her appearance and scholastic abilities, as well as guilt regarding her parents' marital problems. So some of the significant statements there that we should pay attention to as clinicians. Interpersonal relationship difficulties, so that just speaks to these symptoms be impacting the social aspect of her life. We even understand that back here in this phrase with not getting along well with classmates. So whatever this is impacting her ability to have interpersonal relationships. Her persistent negative thoughts about self and her abilities, that really can speak a lot to depression, low self-esteem, low self-concept, as it says back here. And it could, lend itself to anxiety as well, kind of doubting her abilities. Also, it says guilt, and it said guilt back here too. So part of depression oftentimes is inappropriate guilt, meaning people attribute guilt to themselves, or attribute kind of failing and external circumstances. They attribute that to themselves as though it's their fault. Or inappropriate guilt is they may feel that they are contributing to the situation way far above and beyond than should be attributed to them. So inappropriate guilt is really quite a sign of depression. And it says it's about her parents' marital problems, which is also pretty typical for adolescents to feel like they are contributing to the parents' marital problems, especially if they've been fighting about needing to move her to a different school because of her behavior. So it kind of speaks to reason that she feels guilt, at least some degree of guilt over her parents' marital problems, because they need to find her a new school because she hasn't been doing well. So There is some guilt there that I would say is kind of normal, although, beginning to blame her parents' marital problems solely on herself, that kind of goes down the lane of inappropriate guilt. Let's continue on then and find out this last part. It looks like the patient's medical history, she suffers from asthma and uses eyeglasses, which doesn't really affect us or mental health too much, at least that we need to really be concerned. This is the one, though, that it looks like she's becoming overweight. And what we know is that there is a kind of a bi-directional relationship between depression and gaining weight or obesity. It's a vicious cycle. Those who are depressed oftentimes become much more sedentary lifestyle. They become inactive. It leads them to kind of eat more or gain weight, or the only way that they can suppose that they can find any sort of pleasure or energy or desire is to snack. That snacking turns into excess weight. They begin to look at themselves in the mirror and low self-esteem because of their self-image. And here we go. It's just an amazing detrimental cycle that they get into. Looks like the mother states, and this is critical, looks like she reports that the daughter was previously diagnosed with depression 3 years ago and then was treated off and on for 2 years with counseling and antidepressants. So that is crucial. So here we go. There was a previous diagnosis of depression, so that's going to be very helpful when we formulated depression, because if she's previously had one, that changes our diagnosis a little bit. And then it looks like she was treated off and on with both counseling and antidepressants. It looks like she's had fluoxetine, which is Prozac, and sertraline, which is Zoloft, I believe. But there's no dosage information. So it depends on how she reacts or reacted to those two, but that's something to consider as part of our treatment recommendations, is to remember, though, that she was previously on medication. So we're going to want to ask, were they effective at some point, so that we can kind of refer her back to psychiatry. It says it looks like her first depression was triggered by a rejection of a boy that she had romantic feelings for. And then her current symptoms are related to her parents' marital problems and academic and school difficulties. So, wow, there's a lot to chew on there. From all of this, what I'm gaining, so let's roll some of these things out here real quick. Let's bring out the old black highlighter. Let's rule out oppositional defiant. I'm not saying that she's being any sort of defiant towards her parents, towards teachers, authority figures. She may have had some spats with some issues with classmates, but it doesn't seem like it's gone anything overboard. So I'm going to cross out oppositional defiant. Let's jump to bipolar. Lack of concentration, maybe some irritability, may speak to bipolar. She's got a family history of bipolar, but you know what? There's really nothing here at all that says that there's been any sort of manic episodes, impulsivity, bursts of energy, grandiosity, any of that stuff that would indicate any bipolar issues. However, in the future, that it may be lying dormant. She may have the potential, so she better kind of keep an eye on that. But right now, we're going to cross out bipolar because there's really no indication of any sort of manic issues. I will jump to kind of the obvious one. There's plenty of criteria throughout this section right here in yellow to indicate that major depression definitely is kind of winning the race as far as a diagnosis that I would give. And anxiety, although I don't see that it's saying that she's generally kind of worried. Obviously, she's stressed about kind of her parents' marriage. She's stressed about her failing grades. But it's not speaking much to the worry in this scenario. It mentions that she's anxious back here in her symptoms. But again, it's not speaking to general worry, and it doesn't really mention much more about it. And so for right now, I'm going to keep that on my radar. So I'm just going to kind of change that to maybe blue, as indicating if some sort of maybe provisional or rule out as potential some sort of underlying anxiety. But for right now, I'm going to say that her depression, or her primary diagnosis, and let's figure this out then. Her primary diagnosis is major depressive disorder. It's going to be recurrent, which means she's had a previous episode, and that's because of this statement right back here, that she's had it 3 years ago. So it's major depressive disorder, recurrent. And, because of the difficulties of failing school, interpersonal relationships, issues with classmates, this really is going a little bit beyond mild. However, it doesn't say she's having any suicidal thoughts or intent or anything. However, it really is kind of affecting her daily functioning to the degree where you could put mild to moderate. I'm going to probably put moderate just because it seems to be headed in the wrong direction, and it really is impacting her functioning at home and in school. It's kind of getting to that degree. The good thing, though, from a strengths-based perspective, I don't see really any suicidal ideation at all, which is great. There is a sense of hopelessness. We would want to explore what that hopelessness means and do some sort of risk assessment and figure out what that is. Let's talk treatment really quick. As I mentioned, she's had previous psychiatric treatment as well as counseling. I would explore how effective those were. So as far as treatment recommendations, I would say kind of referral. I would refer to her PCP, primary care provider, for a med eval. I would also refer her or keep her on as a client. I would likely do some sort of CBT based counseling to deal specifically with the persistent negative thoughts about herself and scholastic abilities. So I'd probably do something in that realm, CBT based. But because of also the family stress, the marital stress, all of that stuff, I would also probably concurrently recommend family treatment, family counseling, to help with kind of what's going on with her parents' relationships. I think that's appropriate. This kind of larger picture, CBT, family treatment, and a referral to a primary care provider for a med eval. That's where I would go. As far as treating her for depression, I would also include anxiety and her anxious symptoms as part of that treatment, even though I may not put any sort of anxious or diagnosis of anxiety. I would still include that as part of kind of treating the depression. I would just include anxiety as part of the symptoms. We could look at doing a major depressive disorder, recurrent, moderate, and put a specifier potentially with anxious distress. That may be appropriate in this situation. But for now, this is kind of how I would keep it, and just kind of treat the anxiety as part of the kind of depression, or at least an underlying working diagnosis to see if that changes. So there you go. That is the case of the 15-year-old Puerto Rican adolescent female. Thanks.